Hello everybody. Today we will talk about selected respiratory tract diseases. We have a long list of respiratory diseases. However, during this lecture we will only discuss a few of the common respiratory diseases that are characterized by being obstructive diseases. First of all, we want to know what's the meaning of an obstructive pulmonary disease and what's the difference between obstructive disease and restrictive disease. Obstructive diseases, from its name, they are characterized by limitation of airflow، يعني صعوبة في دخول الهواء إلى المجاري التنفسية. And the causes for obstructive diseases are either partial obstruction or complete, total obstruction, like what happens when you have a tumor obstructing the bronchus, for example, or a foreign body obstructing the bronchus. Also, we have many diseases that are characterized by partial or complete obstruction of air flow. And this obstruction can happen at any level of the airways, starting from the larger airways proximally to the smaller distal airways. Sometimes these conditions are either characterized by narrowing of the lumens of the bronchi، يعني تضيق في القصبات الهوائية، like what happens in asthma، مرض كتير معروف، and in COPD, chronic obstructive pulmonary disease, the chronic bronchitis type. Or they can show loss of elastic recoil، نقص في elasticity لللنج tissue، وبالتالي راح يصير في loss of elastic recoil and this is characteristic for emphysema. The other group of pulmonary conditions are called restrictive pulmonary diseases, and we will not go through them because they have a very long list and they are less common than the obstructive diseases. In the restrictive pattern we have reduced expansion of the lung parenchyma، يعني elasticity of the lung بتقل، وبالتالي بصير في fibrosis وتراكم للكولاجين، let's say, and this will inhibit the expansion of the lungs. A lung you can view it like a balloon, so like you can't inflate this balloon, and it is characterized by the decreased total lung capacity، فقدرة الرئتين على استقبال الهواء بتقل. The causes for restrictive diseases are either chest wall disorders in the presence of normal lungs, or a group of conditions called interstitial lung diseases, whether acute or chronic. So we will discuss a few of the obstructive pulmonary diseases. And the major diseases that we will discuss are emphysema, chronic bronchitis التهاب القصبات المزمن, and asthma, which is called الربو. Actually, we have a lot of overlap between these conditions. So we have an emphysema in which there is an alveolar wall destruction. الالفيولاي اللي هي الأكياس الهوائية الموجودة في اللنج، فبيؤدي في النهاية إلى overinflation of the whole lung. And the other disease, which is chronic bronchitis. Both of these conditions are small airway diseases, and they are related to the injury caused by smoking. One of the major causes of emphysema and chronic bronchitis is smoking. Chronic bronchitis and emphysema have an overlap area here in which there are the symptoms or the signs of both conditions in the same patient, because both of them are caused by the same pathogen, which is or injurious agent, which is the smoking. However, there are many differences in the clinical picture of both conditions. The other disease, which is called asthma or hyperreactive airway disease, which is usually triggered by allergens, allergy وتفاعلات الحساسية أو sometimes viral infections, in which the airway obstruction here in asthma is called reversible airway obstruction. I will talk about it later in the lecture. So we have emphysema, chronic bronchitis, and asthma, And there is an overlap area here between all of these diseases. So let's start with the first one, which is emphysema. Emphysema, the hallmark for emphysema is permanent enlargement of the air spaces اللي هي الحويصلات الهوائية distal to the terminal bronchioles اللي هي الأكياس الهوائية اللي بيصير فيها تبادل الأكسجين بين الدم واللنج tissue. The emphysema is characterized by destruction of the walls of these alveoli, so all of these alveoli will open on each other. كلياتها بتفتح على بعضها وبتصير عبارة عن like كيس كبير. There is definitely no significant fibrosis in emphysema, and this is what characterizes emphysema by histology, not by clinical picture. By histology, if you are talking about histology, there is no fibrosis, only destruction of the alveolar spaces. And as we always say, there is macroscopic picture and microscopic picture for every disease. So if you look here, this is the macroscopic appearance of the lungs that are involved by emphysema. Look at the air spaces. Because of the destruction of the alveolar walls, we will be left with a sponge-like زي الإسفنجة surface of the lung, in which normally the lung looks like a sponge, but the spaces are very, very small and tiny that we can't usually see them perfectly on the macroscopic appearance. But here you can see a very, very large spaces. The alveolar spaces are open into each other, so they will form like a larger sac-like زي الأكياس الهوائية, and histologically microscopic appearance in which the air spaces, we have loss of the alveolar septi here and loss of them here due to the destruction. So the alveolar spaces, as you can see here, are very large and open into each other, and they are filled with air, مملوئين بالهواء, وهذا اللي بيسبب الhyperinflation of the lungs in patients with emphysema. And look that we don't have any fibrosis here. We have many types of emphysema, and the basics for their differentiation is the anatomic location of the changes within the lung lobules. What is the lobule of the lung? The lobule is defined as a cluster of 3 or 5 acini. الأسيناي هم الاير سبيسز أو الحويصلات الهوائية. كل 3 إلى 5 بيعملوا لنا lobule. What is the acinus? الأسينس هو structure that is distal to the terminal bronchiole اللي هي مجموعة الحويصلات الهوائية. كل مجموعة من الحويصلات الهوائية لحد 3 إلى 5 بتشكل لنا اللوبيول، فبيكون شكلهم زي عنقود العنب. كيف حبات العنب هم بيشكلوا الأسيناي، وكل مجموعة من الأسيناي مع بعض بيشكلوا لنا لوبيول، واللنج كلياتها مكونة من مجموعة كبيرة من هدول اللوبيولز. هلا التايبس اوف emphysema بنقسمهم إلى the two main most common types هم ال central acinar emphysema which is more common and the pan-acinar emphysema in addition to the distal acinar emphysema and irregular emphysema. We will concentrate on the first two, which are the central acinar emphysema and the pan-acinar emphysema. So what do we mean by central acinar and pan-acinar terms? This is the structure of the normal acinus. This is the respiratory bronchiole, and these are called alveoli. This is the normal acinus. مجموعة الأسيناي زي ما حكينا بيكونوا اللوبيول، فبيكون شكلهم زي الجريبس عنقود العنب. This is the meaning of central acinar, in which we have the central or the proximal part of the normal acinus just involved and the distal part is spared. And here we have the pan-acinar, in which the whole acinus, proximal and distal parts are involved. So the centroacinar emphysema, in which we have the central or the proximal part of the acinus is involved or affected first. Now later in the disease, when we have the whole acinus affected, but earlier in the disease it's just the proximal part, but the distal alveoli are usually spared. In the centroacinar emphysema, the most common cause of it is the cigarette smoking. So it's usually the centroacinar caused by smoking, and it affects the upper lung lobes much more commonly. other type of emphysema is called pan-acinar emphysema, in which all the acini are involved, the proximal ones and the distal ones in the acinus, and usually it affects the lower lung zones more, and it is associated with alpha-1 antitrypsin deficiency, which is a disease that also affects the liver, and it is an inherited disease. So the centroacinar emphysema is caused by smoking. However, the pan-acinar emphysema is caused by alpha-1 antitrypsin deficiency. If the patient has an alpha-1 antitrypsin deficiency and he is a smoker, so he will have both types, the centroacinar and the pan-acinar. This is the macroscopic appearance of the lungs that are affected by emphysema. The basic concept in emphysema that we have airspace destruction, and so we will end with a lot of bulli like these. We call them bulli, زي أكياس هوائية, distributed even all over the lung. Even if we cut the lung in a sagittal section, we will find these large air spaces, or what we call bulli, أكياس هوائية. This is a typical appearance of a lung with emphysema. Regarding the pathogenesis of emphysema, whether it is centroacinar or pan-acinar or the other types, the basic concept is that there is a damaging effects. These damaging effects could either be due to environmental exposures, like the most common one is the tobacco smoking, in addition to fuels and others. بالإضافة إلى الجيناتيك factors, one of the main most important genetic factors is the inheritance of the alpha-1 antitrypsin deficiency gene. So either these environmental factors or these genetic factors, they will affect the normal cells in the lung, the epithelial cells lining the alveoli and the bronchi, the cells of the mesenchymal cells and fibroblasts, بالإضافة إلى الانflammatory cells. This exposure to these toxins and in addition the loss of alpha-1 antitrypsin will lead to problems in the survival of the normal cells. The reparative functions of these cells are impaired, and there is an individual variation because not all patients who are smokers, they will develop emphysema. So there is some variation in the response to these damaging effects. So there are multiple genetic factors involved in the pathogenesis of emphysema. The main result of all of these cells affected by the toxic effects of smoking, for example, is the destruction, alveolar parenchymal destruction without fibrosis. So we discussed the macroscopic appearance of the lungs, the presence of bulli and the presence of large air spaces, like a sponge-like appearance on cut sections of the lung. Histologically, there is, if we take a biopsy, usually we don't take a biopsy for patients with emphysema إلا إذا مفكرين ب other pathology to exclude it. But usually those patients are diagnosed and managed based on a clinical diagnosis and physical examination. Histologically, if we take a biopsy, we will find a lot of destruction of alveolar walls and expansion of the air spaces or enlargement of air spaces without fibrosis. And there is a loss of the elastic tissue in the surrounding alveolar septi because we have a destruction to the walls, so the elasticity of the lungs will be lost. So during expiration, لما الإنسان يطلع النفس راح يصير في عندي collapse of these air spaces. In advanced cases, we may have bronchiolar inflammation, but the inflammation is more common with the chronic bronchitis, which we will discuss it shortly. Clinical features, يعني شو هي الساينز والsymptoms اللي بيشكي منها المريض with emphysema. The most important sign and the first sign or symptom is the dyspnea, which is shortness of breath. It is an insidious in onset, but it is progressive. يعني بتبلش بشكل بطيء ولكن بتضلها بشكل مستمر إلى الأسوأ. Second, we have also cough and wheezes, especially if the patient if the patient has a coexistent asthma or coexistent chronic bronchitis. So the main symptom for chronic bronchitis is the cough with wheezes, but for emphysema it's the dyspnea, and sometimes they coexist together. Also the patient will have weight loss، يخسر وزن، راح يكون عنده barrel chest. هلا راح نفرجيكم كيف شكل البارل chest. راح يكون عنده prolonged expiration لأنه حكينا في عنا loss of elastic recoil of the lung tissue، فالexpiration بيكون prolonged وطويل وبياخد وقت عبين ما البيشنت يقدر يطلع الهواء اللي موجود بالرئتين عنده. هدول البيشنتس بالرغم من الديزنيا اللي عندهم والهايبر انفليشن of the lungs with air، يعني الهواء بيدخل لداخل الرئتين لكن ما بيقدر يخرج لأنه حكينا في destruction of the walls of the alveoli و loss of elasticity. فمع الوقت بيصير حجم اللنجز يزيد وتصير over inflated with air، زي كأنك عم تنفخ بالون ومش عم تطلع الهواء منه. لكن بالرغم من ذلك ال oxygenation of the blood is good. So these patients are not cyanosed، ما بيكون لونهم مزرق، بيكون بنسميهم البينك buffers. ليش buffers؟ لأنه البيشنت بيعاني عبين ما يطلع الهواء من الرئتين، فبنسميه buffers زي كأنه بيعمل puffing. وبينك لأنه ما في عنده cyanosis. هدول البيشنتس بيكونوا usually عندهم weight loss فبيكونوا slim. This is the barrel chest which I talked about. This is the normal chest of an adult, and because of the overinflation of the chest in patients with emphysema لأنه الهواء بيدخل لداخل الرئتين وصعب يطلع للخارج، فبصير الchest inflated وبيكون شكله بيشبه this is the barrel. فشكل الchest in those patients بيشبه البارل. What are the complications of emphysema? The most important complication of the long-lasting or long-standing emphysema is pulmonary hypertension, secondary pulmonary hypertension due to the hypoxia on the long run. And this will cause pulmonary vascular spasm and increased pressure within the pulmonary circulation. And the pulmonary hypertension will lead to a pressure on the right side of the heart, and with time راح يصير عندنا right-sided heart failure or what we call it cor pulmonale. Also with time راح يصير في عندنا pulmonary failure and respiratory acidosis and hypoxia. Notice that the hypoxia is not present early on, but later on راح يصير في hypoxia, and due to all of these complications, the acidosis and the hypoxia and respiratory failure, the patient may end up with coma. The other obstructive pulmonary disease, which is also very common in cigarette smokers, is the chronic bronchitis. Chronic bronchitis from its name, it's chronic، إشي مزمن، وبرونكايتس يعني في عنا ongoing inflammation of the bronchial tree. The chronic bronchitis is a clinical diagnosis. To diagnose chronic bronchitis, we should have a persistent productive cough، يعني cough productive of sputum في بلغم for at least 3 consecutive months in at least 2 consecutive years. يعني قبل ما يمر 2 years والبيشنت بيشكي منهم من هاي الأعراض ل3 أشهر متتالية في كل سنة منهم، ما بقدر أشخصه إنه chronic bronchitis. And look at the basic cause for chronic bronchitis. It's cigarette smoking, which is also the cause for the central acinar emphysema. That's why patients who are smokers may have a coexistent emphysema with chronic bronchitis. In the early stages of the disease, the airflow obstruction is not that much, or there is no obstruction. It's only the cough productive of sputum. However, if the patient has an already present, for example, asthma, the patient may have a bronchospasm، تضيق في القصبات الهوائية، وwheezes، صفير. لكن إذا ما كان عنده coexistent asthma, it's only the cough productive of sputum. However, with the ongoing disease and later, heavy smokers especially may develop severe chronic outflow obstruction later in the course of the disease. And they also may have a coexistent emphysema. Regarding the pathogenesis of chronic bronchitis, back to the common pathogen, which is the smoking. Smoking is considered an environmental irritant. And this smoking هو اللي بيؤدي لكل الدمج وكل التشينجز اللي بتصير في الكرونيك bronchitis. This will lead to hypersecretion of mucus, الميوكويد ماتيريال أو البلغم. It starts في البداية in the large airways. With time راح يصير في عندي hypertrophy of the mucus glands in the large airways to produce more mucus. With time also راح يصير في عندي ميتابلازيا، goblet cell ميتابلازيا، بيصير في عندنا goblet cells اللي هي المسؤولة عن إفراز الميوكس في الجاستروintestinal tract So we will have goblet cell metaplasia in the smaller airways. Normally, we don't have goblet cells in the small airways. They are just present in the larger airways that produce the mucus. But in cases of chronic bronchitis, due to the smoking, راح يصير عندنا goblet cell metaplasia, and it is bronchitis. Itis means there is an ongoing inflammation, but we don't have here eosinophils in the inflammatory component because eosinophils are usually seen in asthma, not in chronic bronchitis. Regarding the morphology of chronic bronchitis, again, we have macroscopic appearance and microscopic appearance. Macroscopically, the mucosa is hyperemic, reddish, and swollen edematous due to the ongoing inflammation. We have a lot of mucus, layers of mucinous and mucopurulent secretions, and this is the basic finding in patients with chronic bronchitis, the secretions. That's why they have cough productive of sputum. The smaller bronchi and bronchioles also may be filled with secretions. So it is macroscopically the hyperemia, the edema, and the secretions. While histologically, if we take a bronchial biopsy for patients with chronic bronchitis is a disease of the bronchi, so the air spaces are normal. There is no damage on the walls of the alveoli like what we have in emphysema if we have a pure chronic bronchitis. But if we have both of them, we will find changes in the bronchi and in the alveoli. The basic thing that we have is enlargement of the mucus secreting glands. We said that there is hypertrophy, enlarged mucus secreting glands, in addition to hyperplasia also of these glands. So the thickness of the submucosal gland layer is increased. And there are a lot of inflammatory cells, mostly lymphocytes and neutrophils, and sometimes the changes of emphysema may coexist if the patient is a smoker. So this is what we have microscopically. This is the bronchial epithelium here, and this is the lumen of the bronchus. And this is the bronchial wall in which you have a lot of lymphocytes and neutrophils. In this picture here, you find the thickness of the mucosa is increased, and the cause of this increase in thickness is the increase in the number and the size of the mucus secreting cells. هذول كلياتهم mucus secreting cells. So copious amounts of mucus are produced. The clinical features of chronic bronchitis and the complications. Usually those patients are obese. They are overweight, and the main complaint of these patients is the cough productive of heavy amounts of sputum. As a complication for the disease, we will have on the long run hypercapnia, which is increase in the carbon dioxide in the blood, increase in CO2, hypoxemia, decrease in oxygen, and that's why those patients will complain of cyanosis. That's why we call them blue bloaters. Blue bloaters. For emphysema, they are pink puffers, بينما هون they are blue bloaters. With the progression of the disease also, we may have pulmonary hypertension and right-sided heart failure, which is called cor pulmonale. The most important thing also in patients with the chronic bronchitis, due to the copious amounts of secretions that are produced, and they may sometimes obstruct the bronchial airways, is that the patients are prone to infections, recurrent infections requiring hospitalizations. This picture here illustrates the differences between an emphysema, which we call them pink panthers, this is pink panther, and the chronic bronchitis that we call them blue bloaters. Look at the patient with the chronic bronchitis is cyanosed and he's obese, holding the oxygen because there is always hypoxia. And coughing productive of sputum is the main symptom that they complain of. بينما patients with with emphysema are usually not cyanosed, especially early in the disease course. They have a parallel chest, as you can see here. They are called puffers. Look at their lips because of the loss of the elastic recoil of the lung tissues, so that the patients will بيعانوا عشان يطلعوا air from their lungs. But they are not cyanosed. Look at the color is pink, and the patient usually is slim. There is weight loss on the long run, and you can see here holding his cigarette, and here also holding his cigarette as in his hand. The third obstructive pulmonary disease is called asthma or RABU. The difference between asthma, chronic bronchitis, and emphysema is that asthma is an inflammatory disorder بيشبه chronic bronchitis, but the difference is that here the pathogenesis is different. Sometimes or most of the time it is an allergic disorder rather than a smoking related disease. However, smoking may aggravate the condition and the symptoms and the complications in patients with asthma. Asthma is characterized by bronchospasm that is reversible bronchospasm، بينما بالchronic bronchitis تضيق القصبات الهوائية بيكون سببه زيادة thickness of the bronchial wall due to hyperplasia and hypertrophy of the mucus secreting glands. بينما here it is in asthma it is a bronchospasm, muscle contraction in the wall of the bronchi. The characteristic findings in asthma is recurrent episodes. It comes as episodic. It's not a continuous disease. The patient complains of attacks of asthma. In between these attacks, the patient does not complain of anything. He's normal, but or asymptomatic. So there is recurrent episodes of wheezing اللي هي الصفير. This is a characteristic feature in asthma. Also, we can see it in chronic bronchitis. breathlessness اللي هي الدزنية or difficulty in breathing. chest tightness البيشنت بحس حاله بده ينخنق من chest tightness, and there is cough particularly at night and at the early morning. So look at that in asthma, cough is not the principal symptom. It can occur especially at night, awakens the patient from sleep. But the wheezes and breathlessness, chest tightness are the main symptoms. The hallmarks of asthma. We have airway obstruction. This airway obstruction should be intermittent, like it comes in attacks and not continuous. And second, it should be reversible. That's a bronchospasm that is relieved إما لما exposure to the allergen is relieved, or when the patient take the medications to relax the muscles in the bronchi. So it should be intermittent and it should be reversible airway obstruction. The second part of asthma is the chronic bronchial inflammation with a lot of eosinophils. These eosinophils were not there in chronic bronchitis. The third one, which is a bronchial smooth muscle hypertrophy and hyperreactivity. في البداية it is hyperreactivity. So upon exposure to any allergen تعرض البيشنت لغبرة، لدست، لبولنز، حبوب لقاح، لبرفيومز، لعطور، لأي شيء allergic راح يصير على طول في bronchospasm. This is called hyperreactivity. With time there will be permanent smooth muscle hypertrophy. So that's why with the progression of asthma, the reversibility of the bronchospasm will decrease. And again, like chronic bronchitis, we have an increased mucus secretion. So airway obstruction that is intermittent and reversible, chronic bronchial inflammation with abundant eosinophils, muscle hyperreactivity in the bronchial wall, and increased mucus secretion. We We have many subtypes of asthma according to what is the triggering factor to the attacks of asthma. In all of these conditions, the basic concept of reversible intermittent airway obstruction and the presence of eosinophils histologically and mucus secretion are all there, but the triggering factor is different. We have an atopic asthma, non-atopic asthma, drug-induced asthma, and occupational asthma. Atopic from its name, it is characterized by allergic sensitization، فهي نوع من أنواع تفاعلات الحساسية. والبيشنت usually بيكون عنده history of allergic rhinitis أو eczema أو allergic conjunctivitis. The non-atopic asthma, in which the patient does not have these coexistent conditions like eczema or rhinitis, or does not have any family history of atopy. Atopy معناها حساسية. The third type, which is drug-induced asthma, this is asthma that only comes upon exposure to certain types of drugs. And occupational asthma also comes only if there is an occupational exposure to some environmental antigens إلها علاقة بالشغل للpatient، وظيفة الpatient. So those patients with occupational asthma لما يعطل من شغله بتروح الsymptoms. The triggers for any attack in any type of asthma are usually, most commonly, respiratory infections, especially viral infections. So a patient with asthma, he may have an attack of asthma إذا صار عنده مثلا viral rhinitis or bronchitis or viral bronchopneumonia. Environmental exposure to irritants like smoking or fumes or perfumes or whatever. Exposure to cold air or أحيانا stress or exercise in those patients may trigger an attack of asthma. So the first type of asthma is atopic asthma, and it is the most common type. Usually it starts in childhood. It is considered a type 1 hypersensitivity reaction that is IgE mediated، يعني الجسم بيكون antibodies of the immunoglobulin E type, which are usually increased in allergic reactions. Usually in these cases, the patient gives a positive family history of atopy أو حساسية، ممكن of asthma، ممكن of eczema، ممكن of allergic rhinitis or conjunctivitis, or even the patient himself has other coexistent atopic disorders. The attacks of atopic asthma are usually preceded by allergic rhinitis or urticaria or eczema. And it is these allergic reactions are usually triggered by allergens. These allergens could be like dusts, غبرة, pollens, حبوب اللقاح. That's why the atopic asthma usually gets exacerbated في in the spring في فترة الربيع، لأنه بيكون في كتير pollens والأزهار بتتفتح. أحيانا ممكن التريجر يكون animal dander، مشان هيك أحيانا اللي بيربوا pets في البيت ممكن يزيد الاتوبيك أزمة عندهم. and sometimes some food، في ناس بتصير عندهم الأتاك triggered by some food like strawberries, kiwi, some nuts for example. And in all patients with asthma, either atopic or non-atopic, any infection, upper respiratory tract infection, especially viral infections, can trigger an asthmatic attack. Asthma is called non-atopic asthma. From its name, it's non-atopic, non-allergic, no evidence of allergic sensitization. The patient reports no family history of asthma or other allergic conditions. And if we do the allergic skin test, it is negative. What is the allergic skin test? We inject different types of allergens into the skin, and we wait for a while for an urticarial wheal to appear. If the patient develops an urticarial wheal, that's an elevated reddish area of the skin, that means that the patient is sensitized or allergic to this antigen اللي احنا بنحقنه في الجلد. The triggers for the non-atopic asthma are usually respiratory infections due to viruses or sometimes inhaled air pollutants like smoking, fuels, or other antigenic stimuli من ملوثات الهواء. They are treated in a similar way to atopic asthma. Regarding drug-induced asthma, from its name, it is induced only by the administration of certain types of drugs, and the most common culprit drug in this scenario is aspirin, one of the pain killers, and it's a non-steroidal anti-inflammatory drug. It's an NSAID. It is used as an antiplatelet in many patients over the age of 50 to decrease the risk of coronary artery disease or accidents, thrombotic accidents. Patients who take aspirin and develop drug-induced asthma due to aspirin develop recurrent rhinitis, nasal polyps, لحميات في الأنف, urticaria, and bronchospasm once they take the aspirin. What's the mechanism? The mechanism is that aspirin is a non-steroidal anti-inflammatory drug, and it usually do its action or the mechanism of action is by prevention of cyclooxygenase enzyme to prevent prostaglandin production. But at the same time, it inhibits the cyclooxygenase pathway, and all the arachidonic acid is used by the lipoxygenase pathway, so it will produce substances called leukotrienes. These leukotrienes can cause bronchospasm. So the treatment for such type of asthma is to stop using the medication, and then the patient will not develop the attack. The last type is occupational asthma. From its name, it is due to certain occupational exposures in the patient's occupation. We get information about this type of asthma, or we can diagnose it by the patient history. The patient says that when he goes to work, he develops the symptoms, but on the weekends, the symptoms subside. So usually we should take a good history from the patient. The triggers are usually either the fumes, الناس اللي بيشتغلوا بمصانع بلاستيك, for example, organic and chemical dusts, الوود, الكوتون, البلاتينيوم, الناس النجارين اللي بيشتغلوا في الخياطة في الملابس بالقطن, some gases like the toluene. Usually asthma develops not from the first exposure to these triggers, but from repeated exposure to these antigens. And as I said, the patient tells you that he gets fine during the weekends when he stops the exposure. Regarding the morphology of asthma, again, we have a macroscopic and a microscopic appearance. In fact, usually we don't do biopsies to diagnose patients with asthma. Usually these patients are diagnosed based on the clinical scenario, the signs and the symptoms of the patient, and some radiologic examinations, صور أشعة, for example, السكن تيست في حالة الاتوبيك asthma والnon-atopic asthma. But in certain scenarios we can get a biopsy specimen in order to exclude other causes, and sometimes these findings are seen on autopsy. Macroscopically, the hallmark is overexpansion or overdistension of the lungs, يعني زي الامفيزيما. The lungs are hyperinflated. Why? Because the air enters to the lungs and then it cannot be expelled back due to the bronchospasm. المريض بيعاني عبين ما يطلع الهواء من الرئتين, so the air will accumulate in the lungs and راح يصير في عنا overdistension, يعني زي البالون المنفوخ. Small areas راح يصير فيها collapse due to the mucus plugs. These mucus plugs, because of the production of copious amounts or large amounts of mucus, like in chronic bronchitis, these mucus plugs could obstruct the bronchi and can cause lung collapse. Histologically, we can get nothing because the patient develops the symptoms early in the disease course due to bronchospasm. It's just contraction of the smooth muscle lining of the bronchi. However, with the progression of the disease, we will have inflammatory component like numerous eosinophils. This is the hallmark and that differentiates between chronic bronchitis and asthma. Also, on the progression of the disease, we will have thickening of the airway wall and increase in the number and the size of the submucosal glands that are mucus producing with goblet cell metaplasia. These are the same findings that also we can see in chronic bronchitis. And with time, we will have hypertrophy and hyperplasia of the bronchial smooth muscle. This will lead to permanent narrowing of the bronchi and the bronchioles. فمع الوقت بيبطل الموضوع reversible، ممكن يصير irreversible و not because of the contraction of the muscle but because of the hypertrophy of the muscle, and this will lead to more severe symptoms even at in between the attacks. This is what we usually see upon microscopic examination of a bronchial specimen, many eosinophils. And this is a mucus plug here. شوفوا كيف ماخذ شكل البرونكيال tree. At this mucus plug can obstruct one of the bronchi and cause collapse of the lung. What are the clinical features of asthma؟ أهم شيء تعرفوه إنها الأزمة the main symptom فيها هي ال shortness of breath or the severe dyspnea associated with wheezing الصفير. Wheezes are the hallmark of asthma. You can't diagnose asthma without the wheezes. الوheezes الصفير ممكن نسمعه للpatient by our ears, and we can listen to it by using the stethoscope السماعة. When we examine the chest of the patient, we can hear the wheezes inside the lung. The main difficulty in patients with asthma is during expiration، يعني in exhaling the air، يعني في مرحلة الزفير نتيجة البرونكوسبازم. So the patient will يعاني عشان to expel the air out of the lungs, so the lungs will be hyper inflated. Now the good in these patients that they do not have symptoms in between the attacks. So the patient will have the attack when he is exposed to allergen, for example, or to viral infection. Then in between the attacks, the patient is asymptomatic and free of symptoms. The attacks can last from 1 to several hours, sometimes may be the whole day, and they subside إما spontaneously لما يروح allergic stimulation أو with therapy. The treatment for patients with asthma is mainly by the use of bronchodilators to dilate the bronchi and to relax the smooth muscle in their walls, and the corticosteroids in order to overcome the allergy or to suppress the immune response.